Bismillah ar-Rahman ar-Rahim. We talk in this lecture about imaging larynx. Larynx is voice box. Anatomy of the larynx. The larynx projects forwards in the median part of the front of neck. It extends from root of the tongue to the trachea, laying opposite the third, fourth, fifth, sixth cervical vertebrae. Its upper end opens into laryngopharynx by laryngeal inlet, while its lower end is continuous with the trachea at the level of the sixth cervical vertebrae. Spleen lateral radiograph showing superior and inferior limits of the larynx, indicated by this line. Limits include hyoid bone, epiglottis, and tracheal ring. Hyoid bone to tracheal ring, and thyroid cartilage also seen. This tracheal ring, this thyroid cartilage. Hyperextended neck, centralized 3 mm sections, IV contrast. This important line techniques of the larynx. This lateral radiograph, hyoid bone, thyroid cartilage, and epiglottis. With epiglottis and tracheal ring. As we see in this diagram, we see built of the larynx. Larynx as voice box. This box, it is roof is epiglottis, floor cricoid cartilage. Starting by epiglottis, end at cricoid cartilage. At both sides present laryngeal cartilage bone. We talk about it. There is pre-epiglottic space present in both sides, and this is larynx divided into 3 rules. First one is epiglottic, then subglottic, then glottic. First one, supraglottic space. Supraglottic space starts from epiglottis until false vocal cord. From undersurface of false vocal cord to undersurface of true vocal cord, this is glottic space. Then subglottic space starts from undersurface of true vocal cord to cricoid cartilage. Supraglottic rule, first one, supraglottic space, supraglottic area containing epiglottis, false vocal cord, ariepiglottic fold, arytenoid cartilage. Glottic space, a glottic area containing laryngeal ventricles and true vocal cord. Subglottic space start from undersurface of true vocal cord to cricoid cartilage, containing arytenoid cartilage and posterior commissure. All laryngeal wall lined by mucosa, and this is mucosa is origin of carcinoma of the larynx, which we talked about it before. See in this diagram, this is oropharynx, and this is piriform recess, false vocal cord, laryngeal ventricles, true cord, subglottic airway. Anatomic landmark, hyoid bone. We talking about laryngeal skeleton. Either bird bone or supraglottic. Bird, arytenoid, corniculate, cuneiform cartilage, and bird, thyroid, cricoid, epiglottic cartilage. Supraglottic, we found folliculi, ariepiglottic fold, glossoepiglottic fold, laryngeal vestibule, false cord, ventricle, pre-epiglottic space. This is main subjects, main landmark of the anatomy of the larynx, which we talk about it. First, we start by hyoid bone, then laryngeal skeleton, either bird or unpaired cartilage, bird 3 bone, arytenoid, corniculate, cuneiform, unpaired thyroid, cricoid, epiglottic cartilage, the 3 single. Supraglottic space containing this structure, folliculi, ariepiglottic fold, glossoepiglottic fold, laryngeal vestibule, false cord, ventricle, pre-epiglottic space. Glottic area containing true cord, thyroarytenoid membrane, anterior commissure, posterior commissure. All through larynx, either supraglottic, glottic, infraglottic, we found mucosal surface, submucosal surface, paraepiglottic space. Also, don't forget piriform sinus, recurrent laryngeal nerve, lymphatic drainage. Laryngeal skeleton divided into paired and unpaired cartilage. Paired like arytenoid, corniculate, cuneiform, and paired thyroid, cricoid, epiglottic cartilage. This epiglottis, this is thyroid, arytenoid, and this paired, and this is cricoid cartilage. As we see, this arytenoid, thyroid cartilage, arytenoid cartilage, cricoid cartilage, hyoid bone, and this epiglottis. This epiglottis, hyoid bone, below it thyroid cartilage, below it cricoid cartilage, and arytenoid present in both sides of thyroid cartilage. And this is plain radiograph we show structure of the larynx. Here is folliculi, hyoid bone, epiglottis, pre-epiglottic space. This is thyroid cartilage, as we see, and this is arytenoid, cricoid cartilage. This is different plain radiograph. Ossification of laryngeal cartilage. Thyroid, cricoid, most arytenoid are hyaline cartilage. Ossification begins 25 years. Epiglottis, apex arytenoid, corniculate, cuneiform, elastic cartilage, little tendency to calcify. This hyoid bone, as we see, is the first landmark of the larynx. Single cartilage is considered lingual bone, present below mandible. Anterior midline below mandible, hyoid bone consists of central body and paired lateral and greater lesser horn. Line fusion of the body and the greater horn of the hyoid bone should not be mistaken for fracture. Central and two horn. As we see, this is hyoid bone. As is folliculi present. Normal lucency between body and the greater corneus of the hyoid bone is seen. And this is strap muscles. There is normal lucency between body and the greater cornea of the hyoid bone. This normally, not fracture. Thyroid cartilage, largest cartilage, anterior midline below the hyoid bone, bilateral cartilage plate, bilateral laminae, superior cornu horn, inferior corn, notch, laryngeal prominence. This is thyroid variation in thyroid cartilage. This thyroid cartilage, as we see, and this is cricoid cartilage, mineralization, different variation in thyroid and the cricoid mineralization. This thyroid cartilage, this less mineralized, this well mineralized. Thyroid cartilage, two corner, as we see. This is cricoid cartilage, signet ring posteriorly. This section of the larynx demonstrate what we talk about three roles of the larynx. First one, as we see, this is supraglottic. Then this glottic, this infraglottic. Supraglottic start by epiglottis and are in the surface of the false vocal cord. Supraglottic include false vocal cord. Then between false and true vocal cord, there is glottic area. And this glottic area including laryngeal ventricles. Then subglottic space start from inferior surface of true vocal cord until cricoid cartilage. This is laryngeal ventricle in both sides between false and true cord. This is tomogram demonstrates coronal T1. MR demonstrates, as we see, anatomy of the larynx. As we see in this area, this is pre-epiglottic space, laryngeal ventricles. This is ventricles. As we see, this vestibule of the larynx, This is strap muscles and paralaryngeal space. As we talk, this is very important. May be obliterated in malignancy. As we see this anatomy of the larynx, coronal T1. Sagittal T1 showing firstly epiglottis. This epiglottis, as we see, this is coracoid cartilage, this folliculi, and mylohyoid, gynohyoid muscles. This mylohyoid and gynohyoid muscles, pre-epiglottic space, which containing fat to appear high signal in T1. This epiglottis, this coracoid cartilage, as we see, and folliculi. This is sagittal view of the neck, demonstrate anatomy of the larynx. This is demonstrate anatomy of the larynx. This is pharynx and sternohyoid, thyrohyoid muscles, as we see. This is larynx. This larynx airway. This is arytenoid cartilage. This epiglottis. This hyoid bone, our landmark start of the larynx and the epiglottis, and this trachea, esophagus posteriorly present to the larynx. This is airway, our larynx. This pharynx and this soft palate, this tongue, anterior arch of the atlas. This nasopharynx, oropharynx, and hypopharynx, and this is present larynx. This is esophagus. Supraglottic boundaries, tip of the epiglottis inferiorly to the laryngeal ventricle. Laryngeal ventricle don't included in supraglottic, included in glottic space. Supraglottic contained the epiglottis, glossoepiglottic fold, folliculi, aryepiglottic fold, false vocal cord, arytenoid cartilage, piriform fossa. The structures of supraglottic content. Epiglottis, it is seen leaf-shaped cartilage, anterior border supraglottic larynx, lingual and laryngeal surface, free portion and base, pre-epiglottic space filled with loose areolar tissue. As we see in this image, this epiglottis, and this is anteriorly glossoepiglottic fold attached between epiglottis and the base of the tongue. Divided airway into anteriorly larynx, and this is in both sides is what's called folliculi. And when we go down, we found glottis attached to the base of arytenoid cartilage. This is by aryepiglottic fold. Aryepiglottic fold connect epiglottis to arytenoid cartilage at the base of the vocal cord. Divided airway into central airway, and both sides what's called piriform fossa. Piriform fossa. This is again, as we see, this is epiglottis, glossoepiglottic fold, this folliculi in both sides. This is supraglottic larynx. Supraglottic larynx start by epiglottis until false vocal cord. Its lower limits under surface of the false vocal cord. False vocal cord included in supraglottic larynx content, and then from undersurface of the false vocal cord to undersurface of true vocal cord, it is a glottic area including laryngeal ventricles. And we see suprahyoid portion of the epiglottis. Suprahyoid portion of the epiglottis seen posterior to the folliculi and anterior to laryngeal vestibule. This is sternocleidomastoid. This is mylohyoid. This is submandibular gland. This is suprahyoid portion of the epiglottis. And this is just above thyroid notch. As we see, this is epiglottis. This epiglottis has tapered not nearly as broad as suprahyoid portion. Small amount of air within minimally dilated left saccule, laryngeal ventricles in both sides. This is infrahyoid strap muscles. We talk about strap muscles later on. This is calcification in epiglottic cartilage, unusual finding in elastic cartilage, calcification epiglottic cartilage. Supraglottic larynx we talked before include false vocal cord. This false vocal cord. This is arytenoid cartilage. False vocal cord above and parallel to true vocal cord attaches to thyroid cartilage and arytenoid cartilage apex. Fat density, laryngeal ventricle, invagination of mucosa between true and false vocal cord, laryngeal saccule appendix 2 4 mm project posteriorly from ventricles. This, as we took, false vocal cord attached to thyroid cartilage and arytenoid apex. Attached to arytenoid apex and thyroid cartilage, as we see here. This is what we call supraglottic larynx false vocal cord attached to arytenoid cartilage posteriorly, apex, and thyroid cartilage anteriorly. This is false vocal cord. We know him by its fat density. Fat density. It is filled with fat, mucosal folding filled with fat. Supraglottic larynx. Its landmark, fat density. This false vocal cord. Again, this false vocal cord in MRI. Its fat density, so in T1 a high signal attached posteriorly to arytenoid cartilage, apex, anteriorly to thyroid cartilage. This is false vocal cord, as we see here. It is fat density, level of the base of arytenoid level cartilage and thyroid notch. This is thyroid notch, and this is the base of arytenoid cartilage. Is common carotid, sternocleidomastoid, gagular veins. This is true cord, as we see, and above it false cord. This is epiglottis, this hyoid bone. This is sagittal T1. This is true cord, above it parallel false vocal cord. This is again tomogram demonstrates. This is, as we see, sagittal coronal T1. This is false vocal cord. This true vocal cord in between. It is laryngeal ventricles. This is, we took high signal because it is fat content. This is muscle signal, muscle density. With difference in signal can differentiate between true and false vocal cord. Ventricles, as we see, laryngeal ventricles, arytenoid and cricoid cartilage. This laryngeal ventricles. Cuneiform cartilage, as we see, cuneiform cartilage, ventrifisible corniculate cartilage, ventrifisible corniculate cartilage, and just cephalid to arytenoid cartilage. Aryepiglottic biriform. This biriform, this aryepiglottic fold. Arytenoid cartilage, pyramidal shape, vocal process anteriorly, apex, corniculate cartilage in aryepiglottic fold, muscular process laterally, articular base inferiorly, concave seat on superior border of cricoid ring. Arytenoid cartilage have apex and base. At apex, corniculate cartilage, at base sits on superior border of posterior cricoid ring. This arytenoid cartilage, bird cartilage, and this is base sits in posterior ring of cricoid. Arytenoid cartilage, as we see, this is posterior ring of cricoid. This arytenoid cartilage bilaterally have apex and base. Glottis. Glottis made up of the true vocal cords, anterior and posterior commissure. True vocal cord composed of vocal ligament, vocalis muscle, mucous membrane. 9 to 10 mm thickness, muscular density. Its muscular density differentiated from false vocal cord, which is fat density. Anterior commissure, immovable anterior junction attached to inner pericardium of thyroid cartilage. Anterior commissure, midline mucosal notch between arytenoid. This is posterior commissure. Posterior commissure, midline mucosal notch between arytenoid. Landmarks for true vocal cord. anterior arytenoid cartilage, posterior ring coracoid, this is posterior attachment, anterior and posterior commissure, true vocal cord muscle density, false vocal cord fat density. Other landmark change of airway cavity from multiple to single cavity. This is landmark of true vocal cord. True vocal cord should be symmetrical and centralized. What we mean change from multiple air cavity? Above in supraglottic we found air cavity central and piriform. Above it we found folliculi and central air cavity. When we larynx become a single cavity, this is landmark for presence of true vocal cord. True vocal cord attached to base of arytenoid cartilage posteriorly, false vocal cord attached to apex of arytenoid cartilage posteriorly. As we see, this true vocal cord attached posteriorly to base of arytenoid cartilage, anterior commissure to thyroid cartilage. This false vocal cord attached posteriorly to apex of arytenoid cartilage and anteriorly to thyroid cartilage. This is true vocal cord. It is part of glottic space, glottic rolls, glottic area. This is vocal process as we see. This is vocal process. Arytenoid cartilage, this coracoid cartilage, this true vocal cord. This is fat density, same muscles. And this is, as we see, thyroid cartilage, arytenoid cartilage, coracoid, true vocal cord. This true vocal cord. Thyroid laminae have fused anteriorly, form laryngeal prominence. Soft tissue at the anterior commissure just posterior to prominence and should normally less than 1 millimeter in thickness. This is anterior commissure. Soft tissue posterior to laryngeal prominence. Larynx, true vocal cord. This true vocal cord landmark is we see posteriorly coracoid cartilage, both sides arytenoid, attached anteriorly to laryngeal prominence of thyroid cartilage by anterior commissure. This true vocal cord, this focal process, coracoid cartilage, thyroid cartilage is anterior commissure less than 1 millimeter in thickness. Enhanced axial T1, we show true vocal cord at level of glottis. Vocal cord true signal as muscles, but here we see him in false vocal cord, same signal fat. This true vocal cord posteriorly arytenoid cartilage bilaterally, coracoid thyroid cartilage attached anteriorly by anterior commissures. As we see, this is true mid-glottis, mid-up glottic area, mid-up of true vocal cord, anterior and posterior commissure. This anterior commissure and here is posterior commissures. As we see, arytenoid cartilage, coracoid cartilage, and thyroid cartilage. Subglottic space, where is subglottis? Extend from under surface of true vocal cord through inferior surface of coracoid. It extends from here, from under surface of true vocal cord to under surface of coracoid. This subglottic area. Coracoid cartilage, it is foundation of the larynx. It is landmark. When we see axial section of the neck, we will search for larynx. Start by coracoid cartilage, then up, go to levels of larynx. Complete signet ring, broader posteriorly than anteriorly, articulates with the inferior horn of thyroid cartilage, articulates with base of arytenoid. Posteriorly articulates with base of arytenoid, anteriorly articulates with inferior horn of thyroid cartilage. This is coracoid cartilage, foundation of the larynx. Signet ring cartilage. Subglottic larynx start from under surface of true vocal cord to under surface of coracoid cartilage. This inferior horn of thyroid articulates with coracoid cartilage, and also we see this is coracoid cartilage. Spaces around the larynx. Paraglottic space and preglottic space. Preglottic space anteriorly, paraglottic space in both sides. This preglottic space continuous on both sides by paraglottic space. It's fat density, fat containing. Fat containing preglottic space is seen anterior to soft tissue density epiglottis and extend laterally into paralaryngeal space, then posteriorly into airy epiglottic fold. This is piriform sinus and this is airy epiglottic fold. As we see, this is hyoid bone. Hypopharynx. Hypopharynx, posterior pharyngeal wall, piriform sinus, postcoracoid region. Posterior pharyngeal wall, piriform sinus, postcoracoid region. Two regions have important relation to larynx is piriform sinus and the postcoracoid region. Piriform sinus formed in both sides by airy epiglottic fold extensions. As we see, this is very important. The indent posterior wall of the larynx, piriform sinus. Postcoracoid region is just a lower area of the hypopharynx that covers posterior aspect of coracoid cartilage. This is lower area of postcoracoid region, lower area of hypopharynx that cover posterior aspect of coracoid cartilage. Diseases of the larynx: traumatic, congenital, inflammatory, infectious, granulomatous, mucosal, neoplastic. Neoplasm of the larynx either benign or malignant. Benign papilloma, minor salivary gland tumor, granular cell tumor, chondroma, hemangioma, paraganglioma. Malignant squamous cell carcinoma, non-neuroendocrine carcinoid melanoma, chondrosarcoma, rhabdomyosarcoma, lymphoma. Squamous cell carcinoma is mucosal disease. Squamous cell carcinoma, 90% of all laryngeal neoplasm, mucosal, accessible to direct visualization. Imaging of squamous cell carcinoma, we aiming for what? Where first, site of mass, local extent, pre-epiglottic space, paraglottic, subglottic, and anterior commissure involvement, deep extent, extra-laryngeal spread, cartilage invasion, sclerosis of arytenoid suggests invasion, MR detect fat invasion, non-palpable nodes, secondary versus primary, pre-biopsy avoids confusion. Spread of squamous cell carcinoma of the larynx, direct to adjacent area of the larynx and extralarynx, lymphatic to deep cervical lymph node, supraglottic to upper deep cervical lymph node. Glottis has no lymphatic drainage. Early glottic cancer don't spread to lymph node except after spread to the adjacent area. Subglottic to lower cervical lymph node. Supraglottic carcinoma, 60 to 70% of the carcinoma of the larynx, lymphatic spread 30%. Glottic carcinoma include 25 to 35% of cancer larynx, lymphatic spread 1%. No lymphatic spread not rich in lymphatic glottic carcinoma. Subglottic carcinoma, 5% of total larynx cancer, lymphatic spread 30%. As we supraglottic, glottic, subglottic carcinoma. Squamous cell carcinoma prognosis stage is dependent. According to the stage, survival rate, T1, T2 more than 80%, T3 50 to 60%, T4 less than 40%. If nodal metastasis present, reduce prognosis by half. We use barium swallow to delineate site and extent of the mass, and this is area of thyroid cartilage and ventricle folliculi on both sides. Supraglottic carcinoma, we talk about firstly supraglottic carcinoma. Supraglottic carcinoma include epiglottis, false vocal cord, airy epiglottic fold, arytenoid cartilage. This is origin of supraglottic carcinoma. Mostly arise from base of epiglottis and the false vocal cord. Extension pre-epiglottic space anteriorly, BOT, piriform sinus, anterior commissure. Supraglottic carcinoma more aggressive in direct extension and nodal metastasis, 50% present with nodes, often asymptomatic longer than glottic tumors, overall survival rate 75%. This is squamous cell carcinoma TNM staging of supraglottic carcinoma. Supraglottic tumor, as we see in this widened thyroarytenoid gap, this is thyroid, and see this is thyroid and the arytenoid, widened thyroarytenoid gap invades piriform sinus posteriorly. As we see piriform sinus space obliterated by soft tissue of supraglottic tumor. Supraglottic tumor, as we see. Supraglottic tumor above ventricle. This ventricle which is present between false and true vocal cord. Again, supraglottic carcinoma. This area of soft tissue present in supraglottic area invades piriform sinus on the left side. Irregular soft tissue. Coronary reconstructions of craniocodal invasion and paraglottic extension. As we see in axial CT, we do it for lymph node, and this is in coronal we do what we do it for craniocodal extension and the paraglottic extension. This is supraglottic carcinoma, soft tissue, as we see, thickening, irregular in shape, extended to obliterate piriform sinus, and the paraglottic extension seen in coronal reconstruction, this sagittal reconstruction. Supraglottic carcinoma, this hyoid bone, as we see, soft tissue mass, irregular, invade surrounding structure, obliterate piriform sinus, even we see him down, as this is thyroid cartilage distracted, eroded by this is supraglottic carcinoma, even invade anterior commissure. Again, supraglottic squamous cell carcinoma. This enhanced CT will demonstrate large necrotic epiglottic mass, completely filling pre-epiglottic space, compromising airway, encroaching in airway. This is supraglottic carcinoma. As we see more caudal, we see markedly thickened epiglottis and the airy epiglottic fold infiltrating with tumor. Supraglottic carcinoma, as we see, this is sections below previous sections. What we see caudal to previous slice before, markedly thickened epiglottis, airy epiglottic fold. The second of epiglottis, airy epiglottic fold, second due to infiltration by supraglottic tumor. Metastatic lymph node also identified. Large metastatic lymph node. This is large metastatic lymph node. As we see, supraglottic carcinoma. Enhanced CT demonstrates soft tissue attenuation mass arising from epiglottis and encroaching on the pre-epiglottic and paralaryngeal spaces. This soft tissue mass arises from epiglottis, encroaching in pre-epiglottic and para-epiglottic spaces, obliterate fat. As we see also metastatic nodes present. Right arytenoid fold also thickened, involved with this soft tissue tumor, supraglottic carcinoma. Supraglottic carcinoma extending to arytenoid cartilage, invading arytenoid cartilage. Coronal T1 tumor invasion of paraglottic space. This is invasion of paraglottic space by supraglottic carcinoma. As we see soft tissue invasions, paraglottic space, definitely fat invasion seen in coronal section. Supraglottic carcinoma, this is large, predominantly hypodense anterior epiglottic mass fills pre-epiglottic space at the level of the hyoid bone. As we see, airway compressed by the lesion. Supraglottic carcinoma. Supraglottic carcinoma tumor thickens left side of the epiglottis and extend into a paralaryngeal space and the airy epiglottic fold. This is airy epiglottic fold second, and this is extension of this tumor, supraglottic carcinoma, extending from paralaryngeal space. Normal right airy epiglottic fold. Localized false vocal cord tumor. This one side of supraglottic carcinoma. Carcinoma involving left false vocal cord. This right not involved. See this right fat density. Obliterate normal low attenuation paralaryngeal space and bulges into airway. Normal right paralaryngeal space and normal right false vocal cord. Supraglottic tumor with paraglottic spread to lateral edge of true cord. Paraglottic spread, the soft tissue mass involving false vocal cord involving extended to involve lateral edge of true vocal cord. Supraglottic carcinoma in this coronal extending around the ventricle into true cord. This is mass as we see tumor extending down to involve the ventricle and the true vocal cord. Supraglottic tumor without cartilage invasion. This is supraglottic tumor as we see supraglottic tumor. Tumor involving cartilage. Here tumor involving cartilage spread out of the cartilage, distract it. This tumor, supraglottic carcinoma. Secondary glottic carcinoma. It includes 25 to 35% of laryngeal cancer. Mainly glottic, we talk about true vocal cord. True vocal cord, so easily early symptomatic because change in voice, hoarseness of voice. So it's early detected. So if you ask it what you want type of cancer, maybe we choose this is because early detection. Glottic carcinoma involving true vocal cord, anterior commissure and posterior commissure. Includes 60 to 75 laryngeal carcinomas, present early with hoarseness, nodal metastasis late, 5-year survival, 85 to 90 early, 25 to 55 late. Pattern of tumor invasion, anterior extension into anterior commissure, more than 1 mm thickness to anterior commissure, embrace invasion of contralateral vocal cord via anterior commissure, posterior extension to arytenoid cartilage, posterior commissure, cricotinoid joint, subglottic extension, tumor more than 5 mm inferior to level of vocal cord, deep lateral extension into paralaryngeal space, prognosis T1 carcinoma, rarely metastasis, 2%, and due to absence of lymphatics within true vocal cord. Secondary, we take squamous cell carcinoma and TNM staging of true vocal cord. This is anterior commissure invasions, less than 1 to 2 mm normally, posterior 2/3 of cord intact. This is vocal cord through thickening by tumors, invasion of anterior commissure. This is involve entire right vocal cord. As we see, involve entire right vocal cord, medial displacement of the arytenoid, anterior commissure invasion, thyroid cartilage destruction. This is right cord carcinoma as we talk, and this is laryngeal ventricle, arytenoid cartilage, anterior commissure invasion. It's very important. This is right cord carcinoma involving arytenoid, anterior commissures, and laryngeal ventricle. This glottic carcinoma, carcinoma of true vocal cord. This glottic carcinoma. This is glottic carcinoma as we see. This glottic carcinoma. This is transglottic carcinoma. Tumors exceeding 2 cm in diameter frequently involve cartilage. The extent of this lesion may not fully appreciated clinically due to submucosal spread. Anterior commissure normally not more than 1 mm. Again, this is carcinoma of true vocal cord. As we see, right true vocal cord and thyroid cartilage destruction. Mass involving right true vocal cord invades anterior commissure and destroy right thyroid laminae and extend into adjacent soft tissue. Cortical thinning of the posterior aspect of left thyroid laminae is a normal variation, should not be interpreted as cartilage destruction. Carcinoma right true vocal cord. Transglottic carcinoma, arytenoid cartilage involvement. We see mass in the left vocal cord extended to thyroid cartilage and left arytenoid cartilage. Mass escapes the neck through thyroarytenoid space. Left arytenoid cartilage, as we see, this is left arytenoid cartilage sclerotic due to invasion, and the mass go to the neck regions. Extension may be supraglottic regions. Transglottic carcinoma with tumor with cartilage invasions. As we see, this is revealed soft tissue mass, thickening of mucosa projecting into airway at the level of the cricoid cartilage. Small spread from glottic side, descend to inferior margin of cricoid cartilage, descend to inferior margin of cricoid, and we see replacement of cricoid by tumor, marked cartilage invasion. This is mass. As we see, transglottic carcinoma enhanced axial T2. This is mass, large supraglottic soft tissue mass that invades left paralaryngeal space and left arytenoid and the cartilage, left thyroid cartilage laminae. As we see, sagittal T1 demonstrate full extent of the tumor and it infiltrates level of true vocal cord. This is T1 of previous case. This is transglottic carcinoma. As we see, this is enhanced axial T1 and reveal large, as we see, this is large soft tissue mass invades left paralaryngeal space, left thyroid cartilage laminae, paralaryngeal muscle, sagittal T1 demonstrates full extent of the tumor as it infiltrates level of true cord. PET demonstrate increased FDG activity. This is transglottic carcinoma, tumor follow paraglottic space around ventricle, widening of the cord at tumor infiltration. This is approximate as we see. This is transglottic carcinoma as we see, invading ventricle. This is vocal cord invasion and subglottic extension, tumor within a ring of cricoid, not intact fat plane. This is tumor of anterior commissure extending anteriorly, tumor of anterior commissures. As we see, anterior spread jeopardize anterior commissure, posterior spread threatens posterior commissure. This is carcinoma of left true vocal cord passing anterior to anterior commissure. This clinically fixed left true vocal cord enhanced mass. As we see, this is enhanced mass of the anterior left true vocal cord extend laterally into paraglottic space to thyroid cartilage anteriorly, anterior commissure. Right cord is involved also through anterior commissure, thyroid cartilage intact. As we see, carcinoma through vocal cord. As we see, carcinoma with involvement anterior and posterior commissure. Left through vocal cord extend posterior medially over arytenoid cartilage posteriorly and toward the posterior commissure and anteriorly through anterior commissure. Assessment of cord mobility is essential for cancer staging. T1 lesion imaging may demonstrate no abnormality or may show subtle asymmetry of the cord in T1. Cause a false positive diagnosis of carcinoma include benign polyps and granulomatous disease. Glottic carcinoma, nodular irregularity of true vocal cord, lesion slightly hyperdense, benign polyp may have identical appearance. This T1 stage glottic carcinoma, it may be mistaken for benign polyp, just nodular irregularity of true vocal cord. Glottic tumor may extend superiorly to involve paralaryngeal space and supraglottis and or inferiorly to involve subglottis. Inferior extension is greater than 8 to 9 mm anteriorly and 5 to 6 mm posteriorly, requires total laryngectomy. Subglottic carcinoma incidence 5% of all laryngeal cancer. Inferior glottis to inferior cricoid, late detection due to minimal symptomatology, prognosis poor due to early metastasis to cervical lymph node. Squamous cell carcinoma staging TNM classification. Subglottic carcinoma, as we see, involving area below under surface of true vocal cord. Subglottic carcinoma, commonly subglottic tumors, represent extension from glottic regions to piriform sinus. Subglottic extension from glottic primary cancer usually associated with true cord fixation. Patient often present with dyspnea, stridor pain, over 40% have cervical lymphadenopathy at initial examination. The cricoid cartilage must be intact for successful conservative surgery. Almost 50% of subglottic carcinoma have cricoid or thyroid cartilage invasion at clinical presentation. Carcinoma of right true vocal cord with subglottic extension, destruction of thyroid, sclerosis of right arytenoid as well as cricoid. Carcinoma of true vocal cord with subglottic extension, enhanced CT demonstrates thickening of anterior commissure by mass evolving both true vocal cord. Carcinoma of true vocal cord with subglottic extension, enhanced CT demonstrate mass descends into subglottic regions, perforates cricothyroid membrane and inferior thyroid cartilage to invade soft tissue of the neck, Portion of the mass hypodense due to necrosis. This portion, as we see airway markedly narrowed, prior radiation therapy caused skin thickening. No measurable soft tissue thickness should be demonstrated between cricoid cartilage and the airway. Any soft tissue thickening or exophytic tissue should be considered carcinoma. A special issue in cancer of larynx and hypopharynx. Laryngeal cartilage integrity is an important feature for cancer staging. Presence of cartilage invasion implies T4 lesion, which precludes conservative surgery. Moreover, irradiation of invaded cartilage may predispose to perichondritis and cartilage necrosis. Thyroid cartilage is most commonly affected sites of invasion. Hypopharynx carcinoma, most commonly from piriform sinus, involving piriform sinus apex, postcricoid regions, esophageal verge, larynx. 50 to 78% present with nodes often present late. Piriform sinus carcinoma, as we see, this is dense soft tissue mass partially facing right piriform sinus, infiltrating paralaryngeal space on enhanced CT. Mass approaches right carotid but do not involve the vessel. Normal left piriform sinus, normal left paralaryngeal space. Piriform sinus carcinoma, as we see, thyroid cartilage destruction, extralaryngeal extension. And this is T1 axial image, a large hypointense tumor seen in the region of the right piriform sinus. Fat within medullary cavity or posterior portion of left thyroid laminae is a high signal, as we see. It is a high signal. This is normal. When right thyroid laminae is destroyed, not similar to this, and its medullary cavity replaced by low intensity tumor. Low intensity tumor replaces this fat in the normal left thyroid. Distinction between tumor and strap muscle is poor. The strap muscle and this tumor, here we found fat, no distinction. Tumor abuts carotid artery, do not involve its wall, it is internal jugular vein. Piriform sinus, same case before, as we see thyroid cartilage destruction, this T2 image, strap muscle, and extralaryngeal spid, this T2 extralaryngeal spid, hyperintense tumor, and the strap muscle are better delineated. Contrast enhanced between tumor and the fat within paralaryngeal space is decreased. This is carotid facial sternocleidomastoid. Piriform sinus hypopharyngeal squamous cell carcinoma. As we see, large hypopharyngeal mass extending posterolaterally to upper left carotid artery, displacing barium-filled hypopharynx to the right. Small left jugular nodes are seen. Hypopharyngeal carcinoma CT demonstrates large hypopharyngeal carcinoma that has shown posteriorly to involve retropharyngeal space. Non-squamous cell carcinoma of the larynx. Non-squamous cell carcinoma of the larynx, lipoma-like homogeneous non-enhancing fat density seen at the level of the right area epiglottic fold with intact mucous membrane overlying. This is lymphoma, hypopharynx lymphoma, predominantly submucosal right piriform sinus mass, invades pre-epiglottic right paralaryngeal spaces with effacement of right piriform sinus. This is diffuse large B-cell lymphoma, left piriform sinus, as we see, and this is multiple lesion suggests non-Hodgkin lymphoma. Non-Hodgkin lymphoma CT with contrast show bilateral large submucosal lesions. This is infantile hemangioma subglottic 2 months girl as we see in axial contrast enhanced CT, strongly enhancing subglottic soft tissue mass, characteristic of infantile hemangioma. Axial T2 show high signal, coronal T1 enhanced, we show involvement of subglottis and central trachea. This is right laryngeal space. Supraglottic hemangioma, 58-year man, hoarseness present. Axial CT supraglottic level demonstrates large, strongly enhancing mass involving right false vocal cord. Arrow indicate airy epiglottic folds. Arrow epiglottic fold. Extensive cervicofacial angiodysplasia with laryngeal involvement. Cervicofacial angiodysplasia involvement of floor of the mouth and right epiglottic fold, submandibular space also involved. This is cervicofacial angiodysplasia. It's related laryngeal caput sarcoma. Axial enhanced CT demonstrates supraglottic level, relatively strongly enhancing lesion will involve right high false vocal cord. Cartilage derived lesions, chondrosarcomas, chondromas, chondrometaplasia. Feature differentiated chondrosarcoma from cancer include generally older age at diagnosis, absence of smoking history, predominantly calcified tumor matrix. Chondroid lesions of cricoid cartilage, widening of cricoid cartilage, thickening soft tissue density mass inside. Chondrosarcoma axial CT demonstrate tumor expand thyroid laminae, stippled density within the cartilage. This is chondrosarcoma of cricoid cartilage. CT demonstrates stippled calcifications within a large mass and arising from cricoid cartilage extending into extra laryngeal tissue. Thyroid cartilage is placed inferiorly and to the left. Chondrosarcoma of the cricoid cartilage. Axial contrast enhanced CT demonstrate large hypoattenuating mass with coarse calcification. Characteristic of chondrosarcoma. Mass arise from cricoid cartilage leads to significant airway obstruction. Chondrosarcoma of cricoid cartilage. Chondrosarcoma of cricoid cartilage, widen of the mass by widen of cricoid cartilage by the mass, as we see soft tissue mass destructions and we see this is calcifications. Chondrosarcoma of the thyroid cartilage. T1 show lobulated low signal intensity mass arising from right thyroid laminae. T2 very high signal intensity due to high water content of chondroid erosion. Laryngeal plasmacytoma, epiglottic tumors, plasma cell granuloma epiglottis. L-shaped tumor mass with low signal intensity involving the epiglottis as well as the base of the tongue. Tumor with strong homogeneous enhancement and without evidence of large necrotic area of structure. Plasma cell granuloma epiglottis. Adenoid cystic carcinoma, the subglottic tumor, as we see, large primary subglottic tumor extending beyond larynx, invading cricoid cartilage, no cervical lymph node. Mucoepidermoid carcinoma subglottic, as we see axial CT, we show left-sided mass invasion of cricoid cartilage. Adenocarcinoma, glottic adenocarcinoma, and lipoma, right epiglottic fold. Axial contrast enhanced CT show homogeneous non-enhancing lesion, iso-attenuating to fat level of a right epiglottic fold. Metastasis from melanotic melanoma of left epiglottic fold. Metastasis to the larynx usually occur in the terminal stages of widely disseminated malignancy. Primary tumor of metastasis include melanoma, renal cell carcinoma, lung carcinoma, breast carcinoma, prostate carcinoma. This metastasis from a melanotic melanoma, soft tissue mass present involving supraglottic area, enhanced is coronal T1 with contrast. Metastasis from melanotic melanoma. Granular cell tumor in subglottic regions. Axial CT at level of epiglottis shows enhancing mass that extend into strap muscle. This large enhancing mass extending into strap muscle, granular cell tumor of the subglottic region. Congenital disorder of the larynx, either supraglottic, glottic, subglottic. Supraglottic laryngomalacia, ductal retention cyst, cystic hygroma, bifid epiglottis, saccular cyst. Glottic vocal cord paralysis, weep and atresia, interarytenoid weep, posterior laryngeal cleft, credo chat syndrome, anterior laryngeal cleft. Subglottic congenital subglottic stenosis, subglottic hemangioma, weep atresia and cystis. Subglottic stenosis, membranous and cartilaginous type. Membranous fibrous soft tissue thickening of the subglottic area, cartilaginous thickening or deformity of the cricoid cartilage, McShelf-like. Grading of laryngeal stenosis, grade 1 less than 70%, grade 2 70 to 90, grade 3 more than 90, grade 4 complete destruction. This subglottic stenosis, laryngeal subglottic stenosis. The subglottic stenosis laryngeal conditions, as we see, laryngocele. Laryngocele is dilatation of ventricular saccule or appendix, usually acquired. Laryngomucocele, saccular set fluid field. Laryngocele, air field. Biolaryngocele, it's infected, pus field. It's called a jaw thickening wall in cross-sectional, biolaryngocele. Laryngocele supraglottic abnormality and the true cord is normal. Laryngocele classification either internal, external and combined. Internal 40%, component medial to the hyoid bone inside larynx. External 26%, component lateral to hyoid. Mixed 44%, laryngocele in both sides of thyroid membrane. Etiology of laryngocele increase transglottic pressure, as in trumpet player, excessive cough. Laryngeal carcinoma also produce partial obstruction, increased transglottic pressure causing laryngocele. May be congenital. Most laryngocele acquired. Search for underlying laryngeal cancer if we found laryngocele. Laryngocele, this is internal medial to hyoid bone, this external lateral to hyoid bone, this mixed in both sides. Acquired laryngocele, we see saccular air-filled cystic space lateral to the hyoid bones. This is mixed laryngocele. This enhanced CT show air-filled laryngocele, straddling thyrohyoid membrane, internal component medial to the hyoid bone, and external component lateral to hyoid bone. This is mixed laryngocele. As we see, it's mixed laryngocele, internal and external. As we see, this is trachea radiograph, plain X-ray at level of the larynx. On the right side, we show peanut-sized saccular protrusion can be seen. Which type? It's external type. Which only type that appear on X-ray. Laryngocele saccular cyst fluid field. This is laryngocele saccular cyst fluid field. As we see, axial contrast enhanced CT, supraglottic larynx, fluid field, internal laryngocele, present as saccular cyst, fluid field, internal laryngocele. This is saccular cyst laryngocele, means fluid field. This is cyst. There is 3 cysts present, either saccular cyst, laryngocele, mucosal cyst arise within the larynx, retention cyst, thyroglottal duct cyst arise just outside larynx, includes association with strap muscle. The saccular cyst present as laryngocele. Differential diagnosis of cyst present here is thyroglottal duct cyst or mucosal retention cyst of the larynx. This is a thyroglottal duct cyst seen outside larynx, paraglottic fat, lesion to thyroid, cartilage, fluid field also, thyroglottal duct cyst. This is, as we see, epiglottic cyst of the neck, show epiglottic cyst in the picture as we see. This epiglottic cyst. Injuries of the larynx. We talk about trauma of the larynx. Result from IN. Direct trauma, blunt or penetrating. Trauma result in cartilage destruction, fracture, mucosal laceration, submucosal hemorrhage, membrane rupture, and surgical emphysema. Classification of trauma, either blunt penetrating, inhalation, ingestion, iatrogenic. This is vertical fracture of the larynx. Vertical fracture of the larynx, fracture including thyroid cartilage. Laryngeal fracture, as we see above axial CT, show fracture of thyroid cartilage laminae, not the presence of the endotracheal tube. This is laryngeal foreign body. Complete obstruction may cause death. Incomplete obstruction cause cough, dyspnea, aphonia. Coin in the larynx. Arytenoid dislocation. Crico are, as we see, cricoid, arytenoid. Cricoid and arytenoid. This is arytenoid and this is, as we see, this is arrow demonstrate arytenoid dislocation. Arytenoid dislocation. Inflammatory disease of the larynx. Epiglottitis. Epiglottitis is the inflammation of the supraglottic structure. Radiographic parameters in adult epiglottitis. Measurement difference were significant between groups only for width of epiglottis and area epiglottic fold. Width is the epiglottis greater than 8 mm and the area epiglottic fold greater than 7 mm seem highly suggestive of epiglottis in adult. As we see, this is epiglottis, as we see epiglottic, and this is area of the supraglottic larynx. This is measurement of area epiglottic fold and epiglottis. We measure width of area epiglottic fold. This is width of area epiglottic fold, width of the area epiglottic fold, width of area epiglottic fold behind epiglottis. As we see, this is area, width of area epiglottic fold behind epiglottis. This is characteristic area epiglottic fold measurement, and patient with epiglottis, patient with croup, patient control patient. Area epiglottis and area epiglottic fold second. This is, as we see, epiglottis, and this is area epiglottic fold second. This is in epiglottis, epiglottitis. This is in epiglottitis. As we see, classic thumb print appearance of swollen epiglottis. This epiglottis swollen, and this is pathognomonic of epiglottitis. This is CT scan adult with acute epiglottitis, show column of air around epiglottis. Right side more swollen than left. Hypoattenuating area suggests fluid or early abscess formation within epiglottis. This is epiglottitis. Axial contrast CT of hyoid bone at level of hyoid bone show marked thickening of the area epiglottic fold. Marked thickening of area epiglottic fold and the posterior pharyngeal wall and the platysmy muscles. Posterior pharyngeal wall and the platysmy muscles. We see here edema seen in retropharyngeal space extending to carotid artery bilaterally and the thickening of the false vocal cord. This is epiglottitis. Croup. Croup, it's what means subglottic laryngitis. Croup. Croup versus epiglottitis, characteristic of laryngotracheatis and epiglottitis. Features according to age, onset, cough, posture, drooling, radiograph, cause of treatment. A radiograph, as we see in croup, stable sign, narrowed subglottis, stable sign. This is here we see epiglottitis, thumb sign, enlarged epiglottis, dilated hypopharynx, as we see. This is what called stable sign, subglottic laryngitis, subglottic edema. Croup best appreciated on the EP view, can be distinguished from congenital subglottic stenosis and post-intubation edema by history. Characteristic charge stable appearance of croup result from subglottic edema obliterating normal subglottic shoulder of the proximal airway. This is stable charge picture, charge stable appearance of the croup. This is, as we see, this is stable charge stable appearance of the croup result from subglottic edema obliterating normal subglottic shoulder of the proximal airway. Epiglottic enlargement, either normal variant, proximal, prominent, normal epiglottis, omega epiglottis. May be inflammation, acute chronic epiglottitis, angioneurotic edema, Stevens-Johnson syndrome, causatic ingestion, radiation therapy. Maybe mass like epiglottic cyst, airy epiglottic cyst, foreign body. Airy epiglottic cyst, either retention cyst, lymphangioma, cystic hygroma, thyroglossal cyst, may be symptomatic at birth, will define the mass in airy epiglottic fold. This is case of diphtheria, laryngeal ventricle cartilage, laryngeal cartilage collapsed, and the laryngeal airway occluded. Thyroid and the cricoid cartilage mishappened. Distance between thyroid and the cricoid is diminished. Thyroid, cricoid, all distracted and involved. This is diphtheria. Chronic localized hypertrophic laryngitis. Vocal nodule, singer nodule, etiology. Prolonged abuse of voice occurs commonly in untrained voice users as singers and teachers. Pathology, localized epithelial hyperplasia and or subepithelial organized hematoma of the vocal cord. This is singer nodule as we see present on true vocal cord. Vocal cord polyps, papillomas. Etiology usually complicates an acute violent voice trauma, shouting. Pathology, localized subepithelial edema, edematous polyp, vascular engorgement, vascular polyp, or fibrosis, fibrotic polyp of the vocal cord. As we see, this is polyp of true vocal cord. CT virtual laryngoscopy is a new method demonstrating endoluminal structure of the laryngeal and hypopharyngeal regions, simulating actual laryngoscopy. As we see supraglottic levels of virtual laryngoscopy, this is epiglottis, and as we see, and this is cartilage on both sides. This is level of supraglottic level, and we see hyoid bone, and this is also supraglottic levels as we see on both sides. This is normal anatomy of the virtual laryngoscopy. This next glottic levels, we see vocal cord in both sides and cartilage on both sides, and this is glottic level. And subglottic level, we see present of cartilage, cricoid cartilage, and arytenoid cartilage in both sides. This is some disease present by virtual laryngoscopy. This is right vocal cord thickening. This thyroid cartilage, as we see, this is endoscopy, true endoscopy, optic endoscopy, this axial CT, this virtual endoscopy, what we see in him, this is thickening, as we see, of soft tissue of the cord, also seen here in virtual laryngoscopy. Another case, we see this mass in axial CT, left vocal cord, soft tissue mass, left vocal cord carcinoma. This optic endoscopy, distracted of thyroid cartilage, invades posterior to arytenoids, and we see it in axial CT. Down we see cricoid cartilage, and this is maybe subglottic extensions. What we see, this is area of left vocal cord carcinoma present on virtual laryngoscopy, and this is also we see it and its extension by this coronal image, and this is virtual CT laryngoscopy. CT carcinoma of the larynx and the piriform sinus. What value of phonation scan? Normal subject during quiet breathing at the level of true vocal cord, arytenoid cartilage clearly visible in close proximity to inner margin of thyroid cartilage. Close proximity to inner margin of thyroid cartilage. Right arytenoid larger than left normally. It's quiet breathing, no phonation. During phonation, arytenoid cartilage adduct, go medially to each other and rotate inward, distended piriform sinus, seen lateral to arytenoid cartilage. This during phonation. So this normally, and this is normally quiet breathing, no phonation. During phonation, both arytenoid adduct to each other and distended piriform sinus. Scan during quiet breathing at the level of true vocal cord in patient with clinical fixation of right true cord. Chordal mass displace vocal process of right arytenoid cartilage medially. Vocal process of right arytenoid cartilage space medially. During phonation, left arytenoid moves normally inward. Adducted right arytenoid fixed in abducted positions. This is, as we see, paralysis or vocal cord involved by carcinoma. Role of CT in the diagnosis of vocal cord paralysis. Vocal cord paralysis etiology either congenital, traumatic, neoplastic, systemic, idiopathic. CT signs of cord paralysis. Paramedian position of the cord, displaced arytenoid cartilage, ipsilateral dilatation of the piriform sinus, tilting of the thyroid cartilage, medial positioning and thickening of the ipsilateral aryepiglottic fold, ipsilateral laryngeal ventricle dilatation, ipsilateral pharyngeal constrictor muscle atrophy, peripheral and central vagal neuropathy. Usefulness of laryngeal phonation CT in the diagnosis of vocal cord paralysis. During phonation, arytenoid abduct arytenoid abduct at quiet. During phonation, go medially and inward. This distance between cord tip and the midline of laryngeal airway during phonation. This cord tip distance between and the midline of laryngeal airway. This is midline present in the airway of the larynx. And distance B between tip of cord and this midline, and distance A must be symmetrical. This indicates stretched vocal cord during phonations. Angle between long axis of vocal cord and the midline is very important. This angle between long axis of the midline present in airway and tip of the vocal cord. 29-year-old woman got health. As we see, coronary reconstruction, larynx during normal breathing, no phonation. Larynx at level of the vocal cord appear to be flat without vocal cord protrusion. Here during phonation, they protrude asymmetrically. Vocal cord, its tip meet each other in the midline. This is 65-year-old woman left vocal cord paralysis for 2 years. As we see during normal breathing, both vocal cord away from each other, airway present, this is flat, no abnormality. But in phonation, this is tip of this cord go medially. And this is cord don't move. As we see في asymmetricality, this indicate left vocal cord paralysis. This tip during phonation must go medially inward like this. This is not happen. This impress left vocal cord paralysis. This CT coronary reconstruction phonation. Using CT to localize side and level of vocal cord paralysis. As we see, dilatation of right follicule and the dilatation of right piriform sinus and thickening of and medial positioning of right aryepiglottic fold. Thickening and the medial positioning of right aryepiglottic fold. Dilatation of laryngeal ventricle, as we see, anterior positioning of right arytenoid cartilage and the medial positioning thickening of aryepiglottic fold. This is sign of what? Sign of side of right vocal cord paralysis. Dilatation of right follicule, right folliculum, and the fullness of right true vocal cord, slight anterior positioning of right arytenoid cartilage. This is right subglottic fullness, dilatation of right piriform sinus, and thickening medial positioning of right aryepiglottic fold. This is signs to localize what site of right vocal cord paralysis. This dilatation right piriform sinus and thickening of and medial positioning of left aryepiglottic fold. This is fullness of right true vocal cord. This dilatation of left laryngeal ventricles, left laryngeal ventricle dilatation. This is dilated left oropharynx with thinning and atrophy of pharyngeal wall. This is 54-year-old man with hoarseness. left vocal cord paralysis, left side palatal weakness. CT with contrast, we see left oropharynx dilated, sending atrophy of pharyngeal wall. Dilatation of left piriform sinus, thickening medial positioning of left airy epiglottic fold. This is left, as we see, vocal cord palsy by aortic aneurysm compression. Stridor, what's the definition? Stridor difficulty noising breathing due to partial laryngeal obstruction. Early it is inspiratory, late it becomes both inspiratory and expiratory when obstruction increases. This causes of laryngeal obstruction stridor. Hoarseness of voice, main definition, cough, harsh quality to voice or cry. Lesions in the true vocal cord is causes of hoarseness of voice. This is causes of hoarseness of voice, either vascular, inflammatory, neoplastic, degenerative and deficiency, maybe larynx, myneural junction, vagus nerve, extracranial portion, vagus nerve, intracranial portion, brain stem involvement. Thank you.